Mrs. Sushma Berlier, Mr. Vijay Berlier, their charming family, Dr. Sharma, old friends and new friends. It is really overwhelming to be here. I've had a tremendous welcome, and it is fantastic to see you all coming to listen to something which is very dear to my heart. But first of all, I wanted just to say a few words of what impressed me about Stya Paul when I read the description and did a little more research. I think that philanthropists who have the desire to give something back to the community in this way, where there is such tremendous humanity which comes through in all the descriptions of everything I've heard and read about this very remarkable man, obviously devoted to family and friends and country, but also to promote the cause of women in this environment, is truly exceptional. And what better way to give back than by supporting educational activities for those of all ages, from the young, with 13 schools, through the developing into teenage years at the 16 institutions and the university. To me, this is incredibly special, and I'm very honoured indeed to be part of it. But we've heard now, so I won't reiterate to much length, how many older women there will be in the future around the world. Some of them sail through the menopause without any problems at all, but others do have problems. And there are issues for all women in midlife and beyond. And what I want to talk about a little is how to get the best health and well-being for our midlife women. Now, menopausal symptoms, and as I say, many women don't have these, but about 25% or more do. And I'll show you some pictures relating to India and Asia in a minute. But what I'm going to talk about, first of all, are the symptoms and the use of hormone therapies. And then I will talk about something which is very, very important. And that is those women who reach the menopause early, and thus, if you like, have midlife thrust upon them at an early age, and they need very particular care. And then something which is incredibly important for every single person in this room, whether male or female, and that is trying to prevent chronic disease. So, do women get symptoms when they live in Asia? We often hear, oh, no, they're fine, they don't get anything. But there are papers appearing in the journals which suggest they do. And a paper actually from a Middle Eastern journal suggests that doctors know a bit about it, but are not really comfortable looking after and treating menopausal women at all. Now, if you look at this image, and I will describe what I want you to particularly look at. If you look at the red columns, these are women from the West, and the purple columns are women from Asia. And you will see that hot flushing, yes, it is much more of a problem in the West, but women in Asia do suffer from it. And these sort of symptoms, they don't kill you, no, but they certainly interfere with quality of life, as I'll mention in a minute. And then there are many other important symptoms which get completely overlooked and often not taken seriously. And this is another image which was made again throughout Asia, from the Far East to India and the Indian subcontinent. And it suggests that often other symptoms are important, such as aches and pains, muscle aches and pains. And I see a lot of women from Asia in my clinic in Glasgow, and this is often the predominant symptom. And they don't realize that actually you can help, and it isn't just age. And then, as I mentioned, hot flushing is a bit less important, but it is still there. Now, a lot of you young people here will think, what on earth is a hot flush? I mean, what is it? It's just getting a bit warm. It's nothing serious. But in this image, you will be able to see, and you can see a little spot on the left-hand screen, that it's actually a complex of symptoms. And some women find it unbelievably distressing. And they come into the clinic and they say, do something about this. I cannot stand it any longer. You have to help. And I will talk a little about those who should not receive hormone therapy. And they are sometimes so desperate, they say, please give it to me, regardless. Now, the other thing that many of you will not realize is that hot flushing can go on for years and years and years. And this slide shows that it's only a matter of 2, 3, or 4 years, but that's quite a long time, particularly if you're at the peak of your career or just leading a very busy life in general. And some go on for 20 years or longer. Now, I mentioned that hormone therapy is incredibly successful. And this is an image showing hormone therapies in these large yellow circles. These are large, well-conducted trials. One is where placebo and active treatment are equal. But you can see how overwhelmingly successful hormone therapy is. And this is also true for some of the other symptoms. It helps the muscle aches and pains, the tiredness, the despondency that people have to a moderate extent, at least. Now, so these are the additional benefits, and women who flush at night particularly often have deprived sleep. And I think all of us know what a disaster that is if we're trying to function well. And so we can often help these symptoms with hormone therapies, but many are frightened of hormones in whatever form they come. And I would hope very much to be able to allay some of your fears during the afternoon. Now, one of the common symptoms, which I am going to spend a minute or two on, because it affects all postmenopausal women, virtually, and that is postmenopausal vaginal atrophy. It's something that it doesn't matter what environment you come from. Some of you will get it, and a lot of women will have it to a mild or sometimes very severe extent. And it's extremely distressing, and often women find it very difficult to talk about, which is why I'm mentioning it, so you can mention it to your patients. And it will cause symptoms that are difficult to speak about. But the treatment is incredibly straightforward. But the common symptoms are pain on intercourse, dryness in the vagina and the vulva, difficulty with passing urine, pain, these sort of symptoms, which are very, very distressing. And these are this is actually a population from the Middle East rather than Asia, but I couldn't find these symptoms for Asia, which show the proportion and the sort of symptoms that people do complain of. And what happens is that estrogen at the time of the menopause declines. The ovaries stop functioning, and it is the ovaries that produce estrogen. And the estrogen is incredibly important in terms of maintaining premenopausal health, things like the integrity of the skin and the mucous membranes. And the vagina is very, very sensitive to estrogen. And after the menopause becomes very, very thin, and the tissues don't stretch and they become sore. And so this is what causes a lot of the symptoms. And I have some pictures here. In the premenopause, you can see that the vaginal skins are waved, and so the tissue can stretch. This is how women have babies without doing harm to the vagina in the main. And there's a thick muscle coat and lots of glycogen in these cells. Postmenopausally, this disappears and the tissue gets thinner and thinner until quite often it just bleeds to the touch and is exquisitely sensitive. And this is another example just showing a full thickness picture of the tissues with the different cell layers. And when you see a woman with these symptoms, you obviously have to exclude infection, although infection will often occur at the same time as the vaginal atrophy occurs. And so you may well need to treat it at the same time. Now, vaginal irritants, lubricants, moisturizers, and soaps, simple things that can be stopped if need be. And so it is important to discuss this topic, and then other more significant gynecological problems. And I'm going to talk about a new preparation because I think it's very important to try and introduce some new topics into any oration so that you'll know what to look for, because there are many different things coming along, and this is very important. Now, you may or may not have come across groups of drugs known as the selective estrogen receptor modulators. Now, these have properties of estrogen and properties also that are anti-estrogen. And the aim is to try and find the perfect agent that has all the good things of estrogen and none of the potentially bad. And so many have been developed. For example, tamoxifen. Tamoxifen is used in the treatment of breast cancer, and in the West is used in the prevention of breast cancer in many high-risk women. It's very, very widely taken, and it has some estrogenic effects. It's good for bones and good for tissues generally, but it has the anti-estrogenic effect on the breast. Now, one of the byproducts of the SERMs is that they quite often have a very good effect on vaginal tissues and therefore are extremely successful treatments for vulvovaginal atrophy. And ospemifene now has a license throughout the US and Europe for this purpose, and I'm quite sure it won't be that long before it reaches India. And there have been some good randomized trials to show that that's the case. And the other thing that it can be used for is for bone protection. Estrogen is good for bones, as I will mention later. And so using this agent is promising in that direction. And then it may well be protective for the breast, although we don't have the information for that. Unfortunately, it does have some estrogenic effects and may increase some of the side effects that we would rather not have with estrogens. As I say, I'll mention this a bit later. But it's something to watch out for and think widely for those where estrogen doesn't work just as well as it might. Now, one of the really, really important things which affects women as they age is osteoporosis and hip fracture. Hip fracture is a really significant problem. When women fall about, as they do as they age, and break their hips, a very significant number of them will be dead within 1 year. And for many who do manage to continue living, they have a substantial decrease in mobility and independence, and it causes the most terrible misery. And certainly many of us in Europe have seen this in our own mothers, and it's hugely distressing. We know how good estrogen is, partly from the fact that when estrogen prescription dropped dramatically about 10 years ago, the incidence of hip fracture rose equally dramatically. And so many, many women had hip fractures who perhaps could have avoided them. And this shows why, and that is that the bones get thinner and thinner as estrogen drops. And the longer you're postmenopausal without estrogen, the longer, the thinner the bones will get. Now, you may be sitting here saying, it doesn't affect us, but it does. And this is an image that shows that, okay, it is commoner in white women in Europe. It's very uncommon in black women in Africa, but Asia comes in the middle. And you can see that the numbers increase with age, and as you are all living longer, this gets more and more of a significant problem. So it needs to be faced up to and dealt with where possible. And we know from the very large studies using estrogen and estrogen plus progestogen, which amount to 18 RCTs and 3 meta-analyses, these are complicated, well-done assessments, that combined hormone therapy with estrogen and progestogen is really effective in preventing fractures. And there are good data to say that it is probably as good or better than virtually anything else in early postmenopausal women. And so it is something to keep in the back of your mind, and women should be aware of it. If they take hormones, they should be aware of all the good things as well as all the bad things that we tend to focus on. Estrogen on its own, which I will talk a bit about later in other contexts, has less effect, although many of the studies do show it has some benefit. But it appears that progestogen is additive. Now, we know about the risks. These are newspapers that were published in 2002 and again in 2004, effectively saying HRT is a poison. If you take it, it will kill you. So don't take it. And millions of women stopped taking it overnight. And we've been picking up the pieces ever since. And this resulted, as I'm sure you're aware, from a very large RCT undertaken in the United States, which was a study of chronic disease prevention in women largely over the age of 60. It wasn't looking at symptomatic women of 40, 45, and 50. So it was a different study. And unfortunately, the results got extended to all women, regardless of their age. And so when we think about the side effects, what really did it? There were two things that did it for hormone therapy at the time. One of them was a reported increase in the chance of heart disease, which is really important. And the other was an increase in the incidence of breast cancer, which of course is important, although numerically much less so. Now, why is heart disease important? These are figures for Europe, but I will show you some figures for India as well. There are two reasons here. One is that it is what will take most of us out of this world. Will be some sort of coronary heart disease, stroke, some sort of cardiovascular disease. The other thing is that it rises exponentially after the menopause. And I'd like you to note, just in passing, the figures for breast cancer, which are vastly lower and also don't show this same huge increase with age and in the post-menopause. So when we look at cardiovascular disease and the causes of death in India, you will see cardiovascular disease is at the top in both men and women. And it is really important in women. It is not just important in men. And this is true when you look at women of 25 to 69 or all ages. And this is shown in a different way, which shows cardiovascular disease and diabetes, which, as you know, often go together. Slightly broader age range. Here is India. Here is Bangladesh, right at the top. So this is a real problem. And so one can see that anything that might increase the incidence would be most alarming, and things which might protect are pretty good news. So I think I'd like to take the results of the WHI trial, which showed a modest increase in women with, who took HRT in the whole group, as to why this was the case. And it is really important because I mentioned that WHI was aimed at looking at older women to look at chronic disease prevention. And so if you look at years after the menopause and you look at this panel here, you'll see estrogen and progestin. And yes, in your older women, in your women over 70 particularly, and more than 20 years past the menopause, there is a significant increase. There's no doubt about it. And of course, they dominate the trial overall. And when you look in younger women around the age of the menopause, you see no such increase. And in women on estrogen alone, there is virtually protection. And some studies show protection, some studies show not quite. But either way, it is definitely doing no harm, and estrogen is likely to be beneficial. So this is really, really important. The women we're talking about are okay with hormone therapy, and if anything, do better. Now, I'm going to dwell a little bit on the 13-year follow-up of WHI, which summarizes all the data that come out of this trial.